Okay, so guys, continuing our high yield important topics of obstetrics. Let us start with the second video. In this, we'll be covering most of the antenatal care and history and hyperemesis gravidarum part. Okay, so this history part is basically clinical, but howsoever big or small the cases, history taking is very much imperative. इसलिए हमने उसको भी include किया है. Okay, so the first or the sixth topic of this series is antenatal care. What is antenatal care? Antenatal care refers to the systemic supervision of a pregnant woman to ensure the best health outcomes for both the mother and the fetus. What are the objectives? To promote and maintain maternal and fetal health, to detect high risk pregnancies early, to prevent or manage complications, to provide education on nutrition, hygiene, delivery, and postnatal care, and to prepare for safe delivery and postnatal period. Now, what are the recommended ANC visit schedule? According to WHO, there should be 8 visits or 8 to 12 visits. Okay, the first one up to 12 weeks, second in 20 weeks, third in 26 weeks, fourth in 30 weeks, fifth in 34 weeks, sixth in 36 weeks, and seventh visit by 38 weeks, and eighth visit by 40 weeks, if so required. Okay. Now, according to Indian guidelines, there should be minimum 4 visits, like in which the first visit should be by 12 weeks, the second being 14 to 26, the third being 28 to 34, and fourth being 36 weeks and thereafter. Okay, so these are the minimum 4 visits, and recommended visits according to national health schedule is there should be 7 visits monthly up to 28 weeks, and there should be 2 visits once in 2 weeks, and 4 visits weekly after 32 weeks. So total can be 12 to 15 visits. Okay, but at least 4 visits are necessary. According to WHO, 8 visits, minimum 4 visits, and recommended visits according to Indian schedule is 12 to 15 visits. This is a PSM part. Okay. Now, the first antenatal visit or the booking visit. What happens on the first antenatal visit is history is taken, obstetric, menstrual, medical, surgical, family, and personal. All kinds of histories are asked from the patient. You must be knowing if you have attended your clinical postings. Now, examination, there is general examination of BMI, pallor, BP, pulse, edema, systemic examination of cardiovascular, respiratory, and breast system, an obstetric examination of uterine size, fetal heart. If the pregnancy is beyond 12 weeks, we can detect fetal heart sounds, and also a pelvic examination will be done. What are the routine investigations which we do? There are blood tests of hemoglobin, blood group, and RS typing, the VDRL test, HIV test, HBS antigen test, and blood sugar level. In urine, we test for albumin, sugar, and microscopy, and of course, we do the urine pregnancy test because HCG is excreted in urine as well. That's a like basic test for pregnancy, right? In other tests, हम लोग कर सकते हैं ultrasound, dating scan around 8 to 12 weeks, and pap smear if not done before, and TSH and thalassemia screening as and when needed. What are the prophylaxis and supplements given to the mother? So all this is preventive obstetrics, right? Antenatal and postnatal care comes under preventive obstetrics because we do not want the female or the fetus to suffer just because of ignorance. So we are giving them already the prophylaxis, supplements, everything. So iron and folic acid tablets, these are started after the first trimester because these cause hyperemesis gravidarum and are kind of teratogenic as well. So they are started after 12 weeks, 12 to 14 weeks. 60 milligram elemental iron with 500 microgram folic acid is the daily recommended dose, and this has to be continued for the whole of the pregnancy and also for 6 months postpartum. About calcium, 500 mg twice daily from second trimester onwards, and deworming tablet can be given. Albendazole 400 milligram after the first trimester, single dose is given. Now, very basic topics. Okay, immunization in pregnancy. We know this: tetanus and diphtheria or TT. First dose is given at the booking if the pregnancy has crossed 12 weeks, and second dose is after 4 weeks. So booster dose is given if fully immunized in last pregnancy within 3 years. Now, monitoring the growth and well-being, we take the measurements, fundal height measurement. We see for fetal heart rate sounds. We look for symphysis fundal height. SFH tracking is done, and weight gain is monitored. Around 11 to 13 kg in singleton pregnancy is expected weight gain in a normal female. Now, ultrasound for fetal growth and anomalies, 18 to 22 weeks, anomaly scan can be done, which is the higher rate scan, okay, the more expensive one. That is the anomaly scan. Now, what are some danger signs to look out for? The bleeding per vaginum, leaking per vaginum, severe headache, visual disturbances, decreased fetal movements, swelling of hands or face, or high BP or convulsions. All these are emergency conditions, because bleeding and leaking per vaginum can correspond to placenta previa. These headache and visual disturbances are high BP, and these convulsions all correspond to preeclampsia and eclampsia conditions. Now, health education during ANC is given. We tell the female about diet and rest, about hygiene and oral care, about the warning signs of pregnancy. We tell her if there is some leaking or bleeding per vaginum, you have to come to the hospital and tell to the doctor. We can also give family planning counseling if the family is complete, or if we can motivate them to practice any method of contraception, then that is also done. Birth preparedness, PPCR, female is counseled that yes, you will have to give birth, so and so things will happen to your body, please don't get afraid. So she has to be morally counseled. And breastfeeding and newborn care, we have to tell her about the importance of breastfeeding and newborn care as well. Okay, so this was a very basic antenatal care part. Now, preconceptional counseling. What is preconceptional counseling? Preconceptional counseling is the guidance given to the couples or women before conception to optimize health and identify the risk, aiming for a healthy pregnancy and fetal outcome. What are the objectives? To improve maternal and fetal health, to identify and manage medical or genetic risk, to promote healthy behaviors before pregnancy, to ensure immunization and supplementation, and to educate about optimal timing of conception. All these points we cover in preconceptional counseling. Okay, so we know, right, the counseling is anterograde and retrograde. Like if something has happened already, then we counsel the parents to as to what to do now or what will happen. And if something can be avoided, like if there are some conditions of the chromosomes whose combination can be dreadful, then we can counsel the parents before the conception as well. So what are the components of preconceptional visit? The medical history is taken. Chronic conditions like diabetes, hypertension, thyroid disorders, epilepsy, asthma. Any previous pregnancy complications like intrauterine growth retardation, preeclampsia, congenital anomalies. Any past infections like TORCH, HIV, hepatitis B and C, and vaccination history. All this is taken as the medical history of the mother. Now, obstetric and gynecologic history is also taken. The menstrual history, parity, abortions, mode of previous deliveries, contraception device used or the method of contraception used, and the history of infertility or menstrual disorders. All these has to be included in preconceptional counseling. Family history is taken if she or her husband is suffering from any genetic or congenital disorders, if there is any disease running in the family, they might be carriers of the disease like thalassemia, Down syndrome. And if there is history of consanguinity, if there is history of cousin marriage, then also there are more chances that genetic diseases will come up. Now, lifestyle evaluation is done if the female does any kind of smoking, alcohol or drug use, if she does diet and exercise, what is the occupation, if there is any occupational exposure or stress to the female. And clinical examination, we do the same things like general BP, BMI, signs of anemia, systemic illness. In systemic examination, we see CNS, CVS, respiratory, thyroid, breast. And in pelvic examination, we assess the reproductive anatomy of the female. What are the recommended investigations? The hemoglobin levels, blood group and RS typing, blood sugar, random blood sugar or OGTT can be done if there are risk factors. Thyroid profile of the female is checked. Rubella, IgG, hepatitis B and C, HIV, VDRL, urine analysis is done. Genetic screening of female is done. Example in thalassemia if history, or if there is any suspicion of the female that she might be a carrier of thalassemia, and pap smear is done if due. Now, what are the immunizations before pregnancy? We have discussed it. Rubella is given MMR vaccine at least 1 month before conception. Okay, so that was antenatal care. Then, when the female has got pregnant. Now, if somebody is planning for conceiving, then we can prescribe them rubella MMR vaccine at least 1 month before conception. Hepatitis B vaccination should be done if she is non-immune. Varicella vaccine will be given if seronegative. HPV for women less than 26 year age, not during pregnancy. Okay, it's given less than 26 year of age and not during pregnancy. And Tdap can be recommended if not taken in adulthood. Supplementation will be started prior to conception. Okay, folic acid will be given at least 400 to 500 microgram per day, ideally started 3 months before conception. High dose, and if there is any history of previous neural tube defects or epilepsy, then high dose folic acid at least 4 milligrams per day will be started. And iron and calcium will be also given if their deficiencies are already present in the female. Now, counseling and health promotion, weight management, underweight female is there, then risk of IUGR is there, and she can also give preterm birth. If an obese female is there, then risk of GDM, gestational diabetes mellitus, and preeclampsia is there. Okay, now healthy diet, a diet rich in fiber, iron, folate, calcium, etc. will be prescribed, and she should avoid harmful exposures like radiation, teratogenic drugs. Control of chronic diseases pre-pregnancy will also be done. Anti-teratogenic drug review is done. Stop or switch the drugs which can be teratogenic like ACE inhibitors, valproic acid, carbamazepine, all these valproic acid, carbamazepine given in epilepsy, retinoids, warfarin in any coagulopathy, and these have to be substituted with pregnancy safe alternatives. Genetic counseling is done if applicable. Family history of thalassemia, Down syndrome, muscular dystrophy, then genetic counseling becomes very, very important. Carrier screening is done for SMA, CF, thalassemia. Okay, and karyotyping can be done if indicated. Now we have to counsel the female regarding optimal timing of conception. Ideally, a conception should occur after 3 months of planning and optimization, and avoid pregnancy till vaccinations like rubella have taken effect. Okay, so all these topics, they might not sound as important, but of course when we do a clinical visit, when we are in hospital setting, then of course antenatal care or preconceptional counseling is very, very important and very, very basic to a person who is posted in the gynecologic department. Okay, so next topic is also related to the same clinical part, which is antenatal history and examination. Why do we take a history? To comprehensively assess the mother's health, identify any risk factors, and monitor fetal development, and plan for safe delivery. A detailed antenatal history is taken. In personal details, we count name, age, address, education, occupation, and socioeconomic status. Every point has its significance, and these are the questions they ask in your vivas, like what's the importance of name, what's the importance of age. So all this has to be essentially asked. Okay, menstrual history is taken. The age at menarche, last menstrual period, cycle length, and regularity has to be asked, because if there are regular cycles, then only we'll be able to apply EDD formula, that's the Naegeli's formula, in which we add 9 months and 7 days to the first day of last menstrual period. Now we have to write the GTPAL formula, in which G stands for gravida, and in T we write TPAL. Okay, in parity we write TPAL, term, preterm, and abortion and live issues. G stands for gravida, the number of pregnancies, number of times she has conceived. P is parity, births more than 28 weeks, abortions less than 20 weeks, living children, and deaths if any. For each previous pregnancy, we have to write the year and mode of delivery, the term or preterm labor, outcome of the labor, whether the child is live, the child was live at birth, if there was stillbirth, if there was neonatal death, and if the child is surviving still. Birth weight of the child, complications like PIH, pelvic inflammatory diseases, okay, and some gestational diabetes mellitus, okay, pregnancy induced hypertension, intrauterine growth retardation, anything if it was there. In medical and surgical history, we ask the female about chronic diseases like hypertension, diabetes, epilepsy, thyroid, TB, asthma, cardiac diseases. We ask her for previous surgeries like if she has gone LSCS, dilatation and curettage, or myomectomy. We ask about family history of diabetes, hypertension, epilepsy, or any genetic disorders like thalassemia, Down syndrome. Drug and allergy history is taken for current medications, and we have to check whether the medication can be teratogenic. If so, we have to either stop or substitute the medication, and we have to ask the female about the known allergies she has. Okay, now the social history, we ask for tobacco, alcohol, and substance abuse. It's also called the personal history. And diet, she has vegetarian or non-vegetarian diet. And if there is some any kind of stress or domestic violence, and how's the support system at home? How are the in-laws? How's the husband? If she has a happy environment at home, or if she is under any kind of stress. Now, lastly, immunization and supplementation will be done. Tetanus TD doses will be asked for, and iron, folic acid, and calcium intake will be asked. Whether you have been prescribed this, whether you are compliant. If not, then we'll prescribe it in the prescription part. Okay. Next up, we do the general examination: the height, weight, BMI, pallor, jaundice, cyanosis, edema in ankle, sacral, and facial areas. Pulse and BP will be taken, thyroid enlargement will be checked, and breast examination will also be done. In obstetric examination, we'll do inspection, abdominal shape and size will be looked for, skin changes, linea nigra, which is the central line extending from the Xiphi sternum to the pubis symphysis, will be seen. Striae gravidarum will be seen. Striae gravidarum are the reddish lines which develop due to present pregnancy. Striae albicans will be seen if there are any prior such lines which have now turned whitish. Umbilicus will be checked if the umbilicus is flat or everted umbilicus, and we'll also look for surgical scars. So this was inspection. Then we do palpation. In palpation, we use Leopold's maneuver. Okay, we do 4 kinds of grips. In first is the fundal grip, and we'll see that what's lying at the fundus of uterus. Second is the lateral grip to assess what is lying at the fetal back. Third is the pelvic grips or the pollex grip. We'll see that what is the presenting part, whether it is the normal head presentation or buttock presentation or facial presentation, whatever. Okay, and lastly we'll see the pelvic inlet grip if the head is engaged or it is still ballotable. Okay, now fundal height we'll see at 12 weeks the fundus and after 20 weeks the fundal height corresponds to the age in weeks. Okay, now at 12 weeks the height is till pubis symphysis. Till 20 weeks it comes to umbilicus. Till 36 week it goes to Xiphi sternum, and after 36 week the head, when the head engages, there is a slight dip called the welcoming sign, lightning sign, which is a welcoming sign in pregnancy. Next up, we do auscultation, in which we check for fetal heart sounds. We detect the fetal heart sounds by Doppler from 10 to 12 weeks, and the normal fetal heart sound should be 110 to 160 beats per minute. We do vaginal examination, okay, usually during late pregnancy or when it's required, okay, not in early cases. Vaginal examination, why it's done? To assess cervical length and consistency. If the cervix is less than 2.5 centimeter, then the female can undergo abortion. So we will provide her with McDonald cerclage. We'll see later in that abortion topic. And we see for effacement and dilatation that these are the processes which occur near labor. Okay, so we will see that whether the cervix has been dilated, whether it has been effaced. Effacement is the eating up of cervix. When due to dilatation, the cervical length reduces, and finally the cervix becomes as if it has vanished. Okay, and we'll see for pelvic adequacy. This part is not very regularly done in early pregnancy unless indicated if there is any past history of abortion or there is any bleeding or pain, then we do it, if everything's normal, we do it towards the end of pregnancy. Now we document all these details. Antenatal card, the Mamta card in Indian system, it includes EDD, gravida, parity, risk factors, investigations, supplements, immunization history, BP, weight, symphysiofundal height, fetal heart rate, and notes from every visit are given on that Mamta card. And we have to educate the females about any danger signs. If she is experiencing anything like this at home, she must go to the hospital and meet the doctor. What are these signs? Vaginal bleeding, severe abdominal pain, swelling of face or hands, severe headache or vision changes, decreased fetal movements, high fever or convulsions. All these can be the danger signs. Okay, so all this was about the history part, like antenatal care, preconceptional counseling, and also the history taking. Okay, now comes a, this is a topic which is like a connecting link. Okay, it's also clinical part, and also in history we have to ask it, because in initial days the female's first and most common complaint in pregnancy after amenorrhea is that she suffers from morning sickness. Okay, that's why I've included all these topics together, because these kind of relate to each other and are to be studied in one go only. Okay, so hyperemesis gravidarum. What's hyperemesis gravidarum? It is excessive persistent vomiting in pregnancy, which leads to more than 5% weight loss, dehydration, electrolyte imbalance, and ketonuria. So, nausea and vomiting in pregnancy is normal in first trimester, but if it occurs excessively, it's called hyperemesis gravidarum. Emesis is vomiting, gravidarum is pregnancy. So, more vomiting in pregnancy is what is hyperemesis gravidarum. It is a severe form of nausea and vomiting of pregnancy and usually occurs in the first trimester and peaks at 8 to 12 weeks. What is the etiology and risk factor? The most important factor attributed to morning sickness is HCG. Exact cause is unknown, but associated with HCG levels, multiple gestation or molar pregnancy can induce this. Increased estrogen levels, psychological factors, primary gravida female, history of hyperemesis in prior pregnancy, female fetus, and thyrotoxicosis. All these can induce hyperemesis. But what's the pathophysiology? HCG stimulates upper GI tract, prolonged gastric emptying is there, hormonal, psychosocial, and autonomic nervous system all are dysregulated. This may mimic or cause even transient hyperthyroidism. In hyperthyroidism also there is nausea, vomiting. This can mimic that also and even cause hyperthyroidism. What are the clinical features? Persistent vomiting, dehydration, malnutrition. Signs to look for are dry tongue, sunken eyes, tachycardia, hypertension, oliguria, ketonuria, and weight loss and electrolyte imbalance, decreased sodium and potassium. The patient undergoes into metabolic alkalosis. In severe cases, this is important. In severe cases, due to thiamine deficiency, the female can undergo Wernicke's encephalopathy. What are the investigations need to be done? Urine ketones are checked positive for dehydration and starvation, and CBC will be taken, hemoconcentration will be measured, LFT will be done, may show elevated transaminases, renal function test will be done, elevated area creatinine levels will be checked, electrolytes will be measured, hypokalemia and hyponatremia are the expected findings, thyroid function test may show transient hyperthyroidism, ultrasound will be checked to rule out molar pregnancy or multiple gestation. The differential diagnosis of the hyperemesis gravidarum can be gastroenteritis. She might have an infection in the gastric or intestinal part, hepatitis, pyelonephritis, peptic ulcer disease, diabetic ketoacidosis, and molar pregnancy. What's the management of hyperemesis gravidarum? Outpatient, in mild cases, we send the female home and the treatment is outpatient department. Like small frequent meals are suggested. She's advised to avoid triggers and she's prescribed oral rehydration solution. First line antiemetics can be given like doxylamine, pyridoxine, vitamin B6, and others can be used like promethazine, metoclopramide, or ondansetron. If there is moderate to severe hyperemesis gravidarum, she can be admitted to the hospital. Inpatient treatment will be given like IV fluids, NS or Ringer's lactate with KCl, antiemetics like IV ondansetron or metoclopramide, thiamine supplementation 100 mg per day, IV to prevent vernix encephalopathy, and we have to correct electrolyte imbalance. Nutritional support will be given to the female. Enteral feeding will be prescribed if oral is not tolerated, and TPN can be given in extreme cases. Total parental nutrition. In complications, the female can suffer from dehydration, electrolyte imbalance, vernix encephalopathy, Mallory-Weiss tear, psychological stress, and in fetal complications, she can suffer from IUGR, low birth weight, and preterm birth. Okay. The prognosis is that the hyperemesis usually resolves within 20 weeks, and good maternal fetal outcomes are there with early recognition and proper management. Okay, so this completes our topic. Next up, we'll be covering the diseases in pregnancy. Okay. Okay. Thank you. Like, share, subscribe. Thanks for watching.